Welcome to Health Matters, where we explore key topics from a primary care perspective. I'm your host, Dr. Sheylan Spencer. Here at Vandalia Health, we are passionate about bridging the gap between primary care and specialty medicine, ensuring that complex medical topics are accessible and understandable for healthcare providers and patients alike. In each episode, we'll dive deep into the latest advancements, best practices, and critical insights to help improve patient care. Thank you for joining me on this journey toward better health. Anand Chockalingam is Professor of Cardiology and Director of Cardiometabolic Program at CAMC Institute since December 2023. His research at the University of Missouri, with over 70 original publications, focused on premature heart failure due to mental and metabolic stress. He collaborates with mindful experts, behavioral psychologists, integrative medicine practitioners, exercise and nutrition scientists to improve heart failure outcomes. He has pioneered Heartful Living, Advanced Cardiac Energetics, ACE, a novelty self-inquiry mindfulness empowerment program for virtual cardiometabolic care. He works with the American College of Cardiology and several medical associations for building physician resilience. ACE reverses biological heart age and premature heart failure by addressing NASH, NAFLD, diabetes, hypertension, and inflammation. He is the director of Diastolic Heart Failure Clinic and Cardiac Rehabilitation, where his team is exploring scalable, integrative programs for heart failure and CKM metabolic syndrome care globally. Dr. Chockalingam, thank you so much for being with us today on Health Matters. We're excited to really talk about CKM, metabolic syndrome, and kind of talk about some of the things that you've been doing here at CAMC. So we appreciate you taking time out of your busy day.
Thanks so much for having me. It's a pleasure.
Absolutely. So Dr. Chockalingam, before we really dive in, I always like to start with just a little bit of background. What first drew you into cardiology, and really more specifically your interest in cardiometabolic care?
Cardiology is fascinating. There is so much we could do, from prevention, primary care, up to doing like a surgeon, invasive procedures in the cath lab, and a lot of innovation has been happening over the last 50 years. I would say more in cardiology than most other fields, and it's a privilege to be a cardiologist. I feel I'm very lucky to have chosen that and been in this area for over 25 years. In the beginning of my career, my research interest was how to make people younger. So this has taken 25 years of my life, and it's probably going to take the rest of my life trying to understand, because it's a very fascinating area.
Absolutely.
And I don't look at it from the cosmetic perspective of looking young, because I'm a cardiologist. I'm looking at the heart from the beginning of my career to see what is causing the heart to age. Can we measure it appropriately, and then guide people who have accelerated metabolic, biological heart aging? Can we make their hearts younger? So that question, if we can impress upon our community, our providers, then I feel we've not only done good cardiac care, we've done good metabolic care, and a holistic approach that really reduces healthcare costs and readmissions and makes a big impact at not only the health level but also the economic level for our society.
Dr. Chockalingam, that is such a beautiful explanation. You kind of talked about where cardiology started, and it seems like in the last bit there's been a paradigm shift how we think about cardiovascular disease in general. We know it's not really just a plumbing issue, but more so, would it be okay to call it a systemic disorder? How has that perspective evolved in your own practice throughout the years?
I've always been aware of the humble truth that all the doctors, all our balloons, stents, medications, procedures, everything that doctors and healthcare providers bring to the table can contribute only about 20 to 25% of anybody's health moving forward. So always there has been a huge chunk of health that we've not been able to impact. And that has to do with half of it is to do with socioeconomic status and
Absolutely.
social determinants of health, and a quarter at least is to do with the level of confidence and trust the individual has. So that is their own optimism. And functional status plays a role too. So these are all the players in anybody's health moving forward. So when I lay this out to my patients, some of them say, wow, if I can participate, let me get involved. Then they ask the question straight away, now how do I participate in my health? So that's when the real conversation starts. And that's how I've practiced all my career. And this is where science is moving also. About 1970s, 80s, when we were starting to do the angioplasties and stents in cardiology, we felt that is going to fix all problems. But now we realize in 2025, with all the multiple modalities of imaging that we do to guide patients and then go to the invasive procedures, maybe half to 2/3 of patients don't have blockages, or the blockages we've already stented appropriately or done surgery, and still they come back with cardiac symptoms. So what are we going to do? How are we going to offer them real value for the health that they need? So that is where I think focusing on metabolic as well as integrative approach becomes even more valuable moving forward.
You describe that, from what I'm hearing, is cardiology right now is moving towards more of like a cardiometabolic piece. I'd imagine that would require just collaboration amongst specialties. In your bio, you talked about working with some psychologists and some behavioral health experts. Tell me what your experience has been throughout your career, how those kind of integrate into your practice.
When a patient comes to us, they are not saying, I have this mitral valve stenosis, fix it. Or I have atrial fibrillation, fix it. They are coming to us saying, I have trouble breathing, or I have palpitation or chest pain, and so many other symptoms. So they just want to get better and go on with their life. So we as doctors, to understand health better, we've specialized into our own niche areas. But sometimes getting a step back, sometimes 2 steps back, to understand what's really going on is the way to a more durable solution. So that's where I feel when we enter into this cardiometabolic space, there are many players in that area. Cardiologists, endocrinologists, nephrologists, pulmonologists, gastroenterologists. So many fields come into this area.
Absolutely.
And then mental health is typically not considered part of the cardiometabolic space, yet in the broader evidence-based literature. But I've integrated that into my AS-based cardiology practice over 25 years ago. So to me, it has always been important to optimize mental well-being. So that is how our patients are getting healthier and getting off many of their medications sooner. So what I learn is both from mental health experts and integrative medicine experts, as well as from my patients. They are showing me what works for them over the time that I've worked with them. So many of their challenges as we work through it over the years, that's taught us quite a bit, that we are now bringing back to the community and saying, this is where you are, this is where you could potentially be, let's work together for a year.
That's a really beautiful way. Sounds like a really multidisciplinary approach. You mentioned being able to kind of target a person's mental health. I feel like that's where primary care can kind of collaborate. Tell me, what are some things that you're doing within your ACE program that's kind of helping patients address that?
The Western medicine, the way we practice it for the last couple of 100 years, that's the duration that we've had this evidence-based science. Before that, every culture had its own traditional medicines. But as we specialized, the way we do it is, there are these problems, how do we fix it? So it's a problem-based or a disease-based approach, which worked until now. But if we want to go beyond where we are currently, I feel bringing positive psychology, bringing this integrative approach into the mainstream will give us so much more value at this stage. So I feel that's how we should explore this a little further and take it from there.
Absolutely. So really addressing that psychological piece, it seems like if we can address a person's mental health, then we can start focusing also on the physical health as well.
See, when you say mental health, again we are moving towards mental challenges like stress and anxiety and depression and other things.
Poor connotation.
So it's not, I mean, just that's the way medical system is.
But mental well-being.
When we say positivity, what I mean is, hey, you are here. What do you want to do in a dream world? Like that we start. So if you come to me for shortness of breath, we're going to have to give you the diuretics or whatever we do to get your breathing better. But then what would you love to do with your time if you had good health? So that is the first interview that I have with the patient. Sometimes they take a while to think about it because nobody's asked them that question, and they themselves have not thought about it because they've been dealing with 6 and 7 issues, 30 medicines for the last 15 years. So they've not even slept in their own bed for the last 6 years. They've been sitting in a recliner next to their bed. We don't ask our patients, are you really sleeping on your bed, or are you watching over your bed on a recliner? So when we ask people, what would you want to do, then comes that hope and optimism building starts right there. So then say, okay, maybe I can do more.
Yeah.
So that trust is so important towards making sustainable big type changes in their way of life and lifestyle.
Absolutely. Thank you for that. That's a good perspective shift. So whenever we talk really just about CKM, this is like a newer term that we're just now, I know at least in primary care, getting used to. And it's an important framework for understanding cardiovascular disease. Are there any specific things that we have here at CMC that are helping patients?
The word metabolic syndrome means diabetes, hypertension, cholesterol, obesity, all these things together cause a cumulative burden to the individual. So they all cluster together in people and cause problems. This we've known for over 50 years. The word CKM, cardiovascular kidney metabolic syndrome, bringing in heart failure, heart attack, kidney failure, strokes, all of that into this metabolic cluster happened only within the last 2 years, when the American Heart Association came out with a statement saying we need to look at this in this broader framework so that our communities will be healthier. And I very much welcome this framework because for the first time, CKM separates obesity from metabolic syndrome. Earlier we thought there is some genetic problem that causes some insulin resistance and other challenges that cause the weight gain. But now they are saying in the CKM framework that the first stage of the CKM is obesity. So when obesity is there, that then leads to hypertension, diabetes, insulin resistance. That then leads to atherosclerosis and stiffness in the heart, kidney issues and heart failure and heart attack. That sort of progression happens over 20 to 40 years. So bringing obesity separate from the other clusters is the big paradigm shift that happened within the last 2 years. And this is allowing doctors to look patients in the eye and tell them, hey, we have your medical issues. There are no excellent medications that can address weight issues.
Absolutely.
So the society is aware of it. More importantly, the cardiology community is waking up to this reality that without addressing extra weight in the body, we might not be able to make our cardiac patients healthier. So that we did not know as a cardiology society until these drugs proved that they can improve cardiac symptoms. So we are moving in the right direction. The CKM framework is going to allow us to do the right research in more longitudinal, outcomes-based, pragmatic research. So we are moving in the right direction.
One of the things that's, I think, really striking about CKM syndrome is how early it begins developing, really maybe even long before a patient ever presents with symptoms. What patients are you finding are most at risk for this? And what are some of the earliest red flag symptoms that you look for?
By the time they come to a cardiologist, people are already having blood pressure for 10 years, diabetes for 7 years, and cholesterol issues for several years, maybe even heart attacks, but that's who we deal with. But this CKM spectrum invites clinicians to take a little longer perspective and look at all of this as a continuum and approach it. So ideally, we want to start prevention.
Absolutely.
Before problems start. So healthy lifestyle is the right start. Eating healthy, exercising, sleeping right, avoiding mental stress, and making sure your metabolic parameters like blood pressure, cholesterol, weight, all of this is optimal. This is primary care.
Absolutely.
But this is the primary prevention too. And this is not something that any specialty can take ownership for. We all have to be part of this so that the patient and their family gets a buy-in and they also contribute.
That's a beautiful way. What are some of the things that we're doing here at CAMC that you've seen really make a difference in patient outcomes?
Inpatients, hospitals?
In patients' outcome.
Yeah, inside the hospital, we have this acute ACE protocol.
Oh, gosh.
So this we've been piloting for about 6 years now. Since I came here, what we've done is we educate the nursing teams and the hospitalists and other specialties involved, saying we are doing standard evidence-based acute heart failure and cardiorenal syndrome care. That doesn't change. But on top of that, for motivated patients, we are offering them some of the early ACE tips so that while they are still in the hospital, they can start learning how they can take a little more ownership for their health in a safe way. Because there are too many changing parameters. Their blood pressure, their volume status, their biomarker parameters, everything is changing every day. That is what happens in a hospital setting. But patients can start looking into certain things the right way so that if they are in the hospital for 2 days or 7 days, in that time, with the help of their team, they are learning how they could sustain these changes, and that reduces readmission rates dramatically for heart failure, which is one of the biggest healthcare burdens, heart failure readmission. So that is an exciting area, and we might in the next year or two develop enough tools that even for patients who are not at CAMC,
absolutely,
outside, Vandalia is a big healthcare system now, so we might be able to offer this type of empowerment to heart patients admitted across our state. So that is our hope in the next year or two.
So I'm hearing evidence-based cardiorenal treatment, and then I'm hearing about early initiation of the ACE protocol. And our listeners probably heard earlier in the episode, we talked about ACE, this being this advanced cardiac energetics. Can you just go a little bit into detail more just for our listeners?
When we say advanced cardiac energetics, what we are talking about is actually something that has been around for 100 million years, what we call ketones. But this is not keto diet. This is not starvation. But people can naturally make ketones when we empower in a certain way. That certain way is what took me 25 years to refine and get it to where it can make an impact within minutes in a patient. So this advanced cardiac energetics is using beta-hydroxybutyrate, which is the ketone molecule.
Absolutely.
That is naturally present in us. We augment it. Changing diet, changing lifestyle, hydration status, and sometimes backing off on some medicines for blood pressure and diabetes allows some ketone levels to come up. And this is how in the acute hospitalized cardiorenal syndrome patients, where really there is no other treatment today, we just wait for them to get better. If their kidney goes down further, we dialyze them. If their volume status goes up, we diurese them. But at the end of the day, we don't have any specific treatments that will make a cardiorenal syndrome or advanced heart failure patient with stiff hearts any better. So for them, if empowerment can allow them to make some ketones, that is the true benefit of this ketones, because there is so little ketones in nature that it's not making any meaningful contribution to the pump, the heart. So if we increase the ketone levels, instead of using glucose and free fatty acids, which our hearts are used to using, If this ketone becomes available, the heart loves it. It's loved it for 100 million years. So once we are able to make that available, there is a good chance that patients will respond better to all our therapies.
That's a beautiful way, Dr. Chockalingam, of kind of framing that for us, talking about the evidence-based treatment with cardiorenal and then just kind of optimizing our body's ability to make ketones. So Mr. Smith, the patient you just saw in the hospital, you did evidence-based care in regards to cardiorenal treatment. You initiated the ACE program early, and he's actually doing really well. The hospital is just looking for discharge. And his follow-up appointment is with you in about a week at the cardiometabolic center. Tell me, what is his first appointment going to look like whenever he comes into your clinic?
So our program is primarily in South Charleston. We also have clinic in Teays Valley, and we do see some patients at Memorial Hospital also. But when people come to us, we are able to offer them we first ask patients to come with their family. So we want this to be their spouse or their child or granddaughter or somebody that will keep them a little more accountable. So we ask them to come. And when they come, we give them a real estimate of their biological heart age. We have 3 metrics that we use, and we show them where their heart's load has been over their lifetime. Most people in society have accelerated heart age of 5 years to 10 years. Our cardiac patients unfortunately have 20, 30, 40-year age acceleration because of, that's why they are coming to us.
Absolutely.
Because their hearts are getting worn out. So knowing what it is and then seeing how they can bring it better, that gives them that, okay doc, I'm going to try and work on it. I'm going to become your next success story. They look at the pictures of people who lost so much weight and who are feeling better. So they look at it and say, doc, I want to be the next success story. So that is when we have their buy-in. Their family is also seeing the patient get enthusiastic. And then in our program, we can do 6-minute walk distance tests to quantify their functional status and the routine things like echocardiogram. And we also have exercise stress echo, where we are able to look not only for ischemia, we are able to look at diastolic stiffness and pulmonary pressure. So it's a very comprehensive evaluation of dyspnea. Not only heart failure patients, even 25-year-olds have trouble breathing, and they sometimes inhibit themselves from activities that their friends are calling. So they end up sitting at home, and that vitiates a cycle where over the next few years they become less and less physically active. So if we can address this dyspnea, that is a big portion of what we do in the cardiometabolic program. Show them what their functional status is, and if the heart or the lung or a combination is contributing to their functional symptoms. So all of this we do in the center, and we initiate remote patient monitoring. So this globally is becoming more and more recognized that hospital is not the right or the only place for healthcare. We need to deliver care where patients are living at home or at work. So if they take a blood pressure at home, we want it automatically to show up in our system. And over days, those trends mean so much more than the one value they get in a clinician's office. So that is where remote patient monitoring, we have ability to call them once a week, and all of that is already reimbursable RPM codes that insurance companies pay for. So we have integrated our ACE in a way that patients come, they feel welcome, they learn how they can be part of their future recovery over the next 6 to 12 months, and they get the remote patient monitoring initiated and whatever tests they need to complete the picture and start the journey.
It's a beautiful kind of walk through Mr. Smith's journey from like the inpatient setting to optimizing ketones to getting the early establishment with you in the outpatient setting. And now we kind of know what a patient appointment looks like at the cardiometabolic center. So I really appreciate you taking the time to kind of walk us through that.
For more than 30 years, CAMC Women and Children's Hospital has delivered more than 75,000 babies, each delivery as amazing as the first. Whether you're a first-time parent or your family is growing, our obstetric and neonatal specialists are ready to welcome your new addition. For more information, visit camc.org.
With more than 30 pediatric specialties on site, CAMC delivers the expertise only a dedicated children's hospital can provide. Right here. For more information, visit camc.org/pediatrics.
For clinicians listening today, whether it be primary care or internal medicine physicians, even residents, what's the one key takeaway that we can start applying to prevent CKM-driven heart failure?
Excellent. What I would suggest is when we start evaluating anybody in the inpatient or outpatient setting, we need to know their CKM load, right? Mm-hmm. What is the burden coming from the CKM? The biggest factors here are high blood pressure and extra weight. Mm-hmm. So blood pressure is obviously there in the chart, but weight sometimes is not something we look at. So I'd like all our clinicians to look at weight and BMI. So once you know the BMI and age, just based on weight, age we call it. Mm-hmm. So add the BMI to the age. If they are below the age of 70 and their BMI is more than 30, then this works. Many of our patients have BMI that is more than 30. Absolutely. I would say about 2/3 to maybe 80% of our patients have BMI that is high. So when we see patients, say for instance, Mr. Smith, you said, his age is say 60, but his BMI was 45. So when we add 45 to 60, it's 105. So that is a simple surrogate for the heart's age. People are shocked. Doc, how is my heart 105 years old? And I show them, this is the blood pressure, this is the weight, and when you bring this down to these levels, your heart will come down to its actual age of 60. There are some people who follow this program, and their heart's age turns out within a year in the 50s. So the weight is not the problem. Weight is the opportunity at this point. So I would invite our providers to look at patients and tell them, ask them whether they have cardiac related symptoms. Many times people have chest pain, but more often they have trouble breathing, effort intolerance, and a lot of times they are on diuretics, sometimes Lasix, but many times on hydrochlorothiazide for leg edema. It might be on for 8 years. They might have gone to a cardiologist, had a cath that showed no blockages, so they think the heart is fine. But the heart, all these 8 years, is getting even stiffer because time makes our hearts stiffer. If you have high blood pressure and metabolic load and CKM issues, it's going to make the stiffness and that's diastolic heart failure challenges even more. So that is what I would encourage our primary providers to talk to patients about. How symptomatic are you? And is it related to your blood pressure and cardiometabolic load and weight issues? So if they have that conversation, then we are happy to take it on and do whatever testing is needed to validate this issue. Sometimes it's lung issues, sometimes it's sleep apnea. A lot of times it's the heart getting stiffer too, because I guess that's where I practice. But if we can evaluate patients, give them the right information, they will more likely than not want to participate in their future health.
Absolutely. That was I think it kind of answered my next question, but you can go ahead and just kind of elaborate on it. Who's the right patient for you in regards to like consultation? Is it the patient with like metabolic syndrome who has a little bit of diastolic stiffening, or what patients are you looking for in regards to consultation?
When we look at it globally, this diastolic heart failure, which means the ejection fraction is fine, there is no coronary blockage, or the stents have already been placed and bypass has been done, or the heart, you cannot revascularize it anymore. So it's doing what it can and the ejection fraction is still normal. but still the heart is going into failure. This we did not even know about 25 years ago as an entity. But now this is about nearly 60% of all heart failure in this country. In Japan, it happens in the 90s. In the US, we see diastolic heart failure in the 70s. But in our cardiometabolic program, where we go after premature heart failure related to CKM issues and hypertension and obesity, what we see is people in their 30s to 60s are developing heart failure. So this is the population that has become our practice to help and guide and impact.
That kind of excites me just really for the future of really cardiometabolic medicine. Dr. Chockalingam, what excites you in the next, 3 to 5 years? It can be specifically here in Charleston or just cardiometabolic medicine in general.
Coming to Charleston has been an eye-opener for me. People here bring two things to our clinical visit. One, they come with family support. This I didn't see in any other part of the country, the way I see it in West Virginia. So family support is so important for any sustainable improvement. Second thing, which is priceless, is the trust. People trust their doctors. So it's a good thing.
Absolutely.
So when the trust is there already, we can move forward very quickly. So that is what my patient experience has been. As far as leadership, this support that I see here in Charleston for bringing this type of integrative care has been tremendous. That's why my time was protected to deliver this care, and I'm loving this opportunity to work with leadership in cardiology, in administration, to come up with more and more creative ways of getting this to our community. We want to take it to policymakers at state level, and they are also interested already to see how our community can become healthier. That's all we are trying to do. And in the next 3 to 5 years, what I would like to see is more of this becoming culturalized. People expecting to get better.
Absolutely.
So
yeah.
that would be the success of what we are trying to build here.
I don't know about you listeners, but that's a lot to be excited about. Not only nationwide, but especially here in West Virginia. Dr. Chockalingam, I feel like this has been a really powerful conversation. Remind us again your current locations and how can we get patients to you?
I'm part of our cardiology group.
Absolutely.
And we are not marketing this AS program outside, although I've been here for 2 years. The reason is there is enough work for us to do within our own group. So, you can just look me up within CAMC. And my office mostly is in South Charleston, cardiology office of CAMC. But we already provide care across Vandalia. Throughout our state, in Vandalia system, we get referrals. So I'm happy to take care of any of our cardiometabolic patients and their families if they are willing to work with us. Because we don't focus on surgeries or injections for weight reduction. People have already tried those, not benefited enough with them, so they come to us. And if they realize that they need to be willing to learn and be open enough to make some changes, then there is a real chance we'll teach our community to do magic on themselves.
Well, you heard it here. This has been Dr. Chockalingam. I feel like a really powerful episode on CKM syndrome, especially talking about the new and exciting things that you're doing with the ACE program here. What to expect on the inpatient setting and versus getting patients to you in the outpatient setting, and some of the beautiful things that you're doing in South Charleston and Taze Valley. So Dr. Chockalingam, thank you so much for sharing your insights and really for the incredible work that you're doing here within Vandalia Health System and Charleston, West Virginia. We appreciate what you're doing to push cardiology forward into the next direction. Thank you guys for tuning in for another episode of Health Matters.
Health Matters Today is a podcast recorded at Vandalia Health Charleston Area Medical Center Studios in Charleston, West Virginia. Hosted by Dr. Sheylan Spencer, directed by Dr. Amy Bruce, produced by Christopher Cobb and Jason Likens.